Hi, you're back, and now we are going to read Chapter 5 of Schwartz Principles of Surgery, and the title is Shock. Okay, it's quite long chapter. You will find this on page 131 up to 152. Are you ready? Okay, let's start. Chapter 5 Shock. Shock is the manifestation of the rude unhinging of the machinery of life. By Samuel V. Gross, 1872. Evolution in Understanding Shock. Overview. Shock, as its most rudimentary definition and regardless of its etiology, is the failure to meet the metabolic needs of the cell and the consequences that ensue. The initial cellularity that occurs is reversible. However, the injury will become irreversible if tissue perfusion is prolonged or severe enough such that, at the cellular level, compensation is no longer possible. Our understanding of shock and the disease processes that result in shock made its most significant advances throughout the 20th century, as our appreciation for the physiology and the pathophysiology of shock matured. Most notably, our comprehension of sympathetic and neuroendocrine stress responses on the cardiovascular system has flourished. The clinical manifestation of these physiologic responses are most often what lead practitioner to the diagnosis of shock, as well as guide the management of patients in shock. However, hemodynamic parameters such as blood pressure and heart rate are relatively insensitive measures of shock, and the additional consideration must be used to help aid in early diagnosis and treatment of patients in the shock. The general approach to the management of patients in the shock has been empiric, assuring a secure airway with adequate ventilation, control of hemorrhage in the bleeding patient, and restoration of vascular volume and tissue perfusion. Historical background. Integral to our understanding of shock is the appreciation that our bodies attempt to maintain state of homeostasis. Claude Bernard suggested in the mid-19th century that the organism attempts to maintain constancy in the internal environment against external forces that attempt to disrupt the milieu intérieur. Walter B. Cannon carried Bernard's observations further and introduced the term homeostasis, emphasizing that an organism's ability to survive was related to the maintenance of homeostasis. The failure of physiologic systems to buffer the organism against external forces result in organ and cellular dysfunction, what is clinically recognized as shock. He first described the fight or flight response generated by elevated levels of catecholamines in the bloodstream. Cannon's observation on the battlefields of World War I led him to propose that the initiation of shock was due to the disturbance of a nervous system that resulted in vasodilation and hypotension. He proposed that secondary shock with its attendant capillary permeability leak was caused by a toxic factor released from the tissues. In a series of critical experiments, Alfred Blalock documented that the shock state in hemorrhage was associated with reduced cardiac output due to volume loss, not a toxic factor. In 1934, Blalock proposed 4 categories of shock: hypovolemic, vasogenic, cardiogenic, and neurogenic. Hypovolemic shock, the most common type, results from loss of circulating blood volume. This may result from loss of whole blood, such as hemorrhagic shock, plasma, interstitial fluid due to bowel obstruction, or a combination. Vasogenic shock results from decreased resistance within the capacitance vessels, usually seen in sepsis. Neurogenic shock is a form of vasogenic shock in which spinal cord injury or spinal anesthesia causes vasodilation due to acute loss of sympathetic vascular tone. Cardiogenic shock results from failure of the heart as a pump, as in arrhythmias or acute myocardial infarction. This categorization of shock based on etiology persists today. In recent clinical practice, further classification has described 6 types of shock: hypovolemic, septic or the vasodilatory, neurogenic, cardiogenic, obstructive, and traumatic shock. Obstructive shock is a form of cardiogenic shock that results from mechanical impediment of circulation leading to depressed cardiac output rather than primary cardiac failure. This includes etiologies such as pulmonary embolism or tension pneumothorax. In traumatic shock, soft tissue and bony injury lead to the activation of inflammatory cells and release circulating factors such as cytokines, intracellular molecules that modulate the immune response. Recent investigations have revealed that the inflammatory mediators release response to tissue injury. The dumps. The damage-associated molecular patterns, or dumps, are recognized by many of the same cellular receptors, or the PRR, the pattern recognition receptor, and active similar signaling pathways as do bacterial products elaborated in sepsis. Pathogen-associated molecular patterns, such as polysaccharide. These effects of tissue injury are combined with the effects of hemorrhage, creating a more complex and amplified deviation from homeostasis. In the mid to later 20th century, further development of experimental models contributed significantly to the understanding of the pathophysiology of shock. In 1947, Uyghurs developed a sustainable, irreversible model of hemorrhagic shock based on uptake of shed blood into a reservoir to maintain a set level of hypotension. G. Tom Shires added further understanding of hemorrhagic shock with a series of clinical studies demonstrating that a large extracellular fluid deficit greater than could be attributed to vascular refilling alone occurred in severe hemorrhagic shock. The phenomenon of fluid redistribution after major trauma involving blood loss was termed third spacing and described the translocation of intravascular volume into the peritoneum, bowel, burned tissues, or crush injury sites. These seminal studies form the scientific basis for the current treatment of hemorrhagic shock with red blood cells and lactated Ringer solution or isotonic saline. As resuscitation strategies evolved and patients survived the initial consequences of hemorrhage, new challenges of sustained shock became apparent. During the Vietnam War, aggressive fluid resuscitation with red blood cells and crystalloid solution or plasma resulted in survival of patients who previously would have succumbed to hemorrhagic shock. Renal failure became a less frequent clinical problem. However, a new disease process, acute fulminant pulmonary failure, appeared as an early cause of death after seemingly successful surgery to control hemorrhage. Initially called Da Nang Lang or shock lung, the clinical problem became recognized as acute respiratory distress or ARDS. This led to new methods of prolonged mechanical ventilation. Our current concept of ARDS is component in the spectrum of multiple organ system failure. Studies and clinical observation over the past 2 decades have extended the early observation of canon that restoration of blood pressure prior to control of active bleeding may result in a loss of blood that is sorely needed and challenge the appropriate The appropriate endpoints in resuscitation of uncontrolled hemorrhage. Core principles in the management of patients in hemorrhagic shock include control of active hemorrhage must occur promptly. Delay in control of bleeding increases mortality, and recent battlefield data would suggest that in a young and otherwise healthy population, commonly injured in combat, the control of bleeding is the paramount priority. Letter B. Volume resuscitation with blood products such as red blood cells, plasma, platelets with limited volume crystalloid must occur while operative control of bleeding is achieved. Letter C. Unrecognized or inadequately corrected hypoperfusion increases the morbidity and mortality. Letter D. Excessive fluid resuscitation may exacerbate bleeding. Thus, both inadequate or unrestrained volume resuscitation are harmful. Likewise, observation in the management of septic shock have led to consensus statements and evolving guidelines based on management. Core principles in the management of patients in septic shock include A. Septic shock is an emergency and treatment. Resuscitation should begin as early as possible. Letter B. Specific anatomic diagnosis of infection requiring emergent source control be identified or excluded as rapidly as possible, and that any required source control intervention be implemented as soon as medically and logistically practical. Letter C. Initiation of broad-spectrum antibiotics within 1 hour of diagnosis. Letter D. The resuscitation from sepsis-induced hypoperfusion, at least 30 ml per kilogram intravenous crystalloid fluid, be given within the first 3 hours, and additional fluids be guided by frequent reassessment of hemodynamic status. Letter E. Vasopressors such as norepinephrine should be added to achieve a mean arterial pressure of 65 millimeters mercury if fluid resuscitation is inadequate. Okay. Next subtopic is current definitions and challenges. A modern definition and approach to shock acknowledges that shock consists of inadequate tissue perfusion marked by decreased delivery of required metabolic substrates and inadequate removal of cellular waste products. This involves failure of oxidative metabolism that can involve defects of oxygen delivery, transport, and/or utilization. Current challenges include moving beyond fluid resuscitation based on endpoints of tissue oxygenation and using therapeutic strategies at the cellular and molecular level. This approach will be helpful to identify compensated patients or patients early in the course of their disease, initiate appropriate treatment, and allow for continued evaluation for the efficacy and resuscitation and adjuncts. Current investigation focus on determining the cellular events that often occur in parallel to result in organ dysfunction, shock irreversibly, and death. This chapter will review our current understanding of the pathophysiology and cellular responses of shock states. Current and experimental diagnostic and therapeutic modalities for the different categories of shock are reviewed, with a focus on hemorrhagic or hypovolemic shock and septic shock. So that's it for the first part. For the part 2, we will read on the pathophysiology of shock. Thank you so much.